I just want to change tack and go back to work for a little while and talk about something that I think we touched on earlier, which
Mm.
makes a really good intensivist. And that is, people don't realize a big job of intensivist is the family communication. Because ultimately, a patient will come into intensive care who's critically ill, might be on a ventilator, so a breathing machine. They have lost their ability to communicate for themselves, and in the meantime, the intensivist's job is to look after this patient to make them better, but at the same time look after the family and give them the right information so they feel well informed. Going through your training, what do you think is the challenges of having really good family communication?
So communication is extremely important in any medical specialty. However, that's taken to a whole nother realm in critical care, be that emergency, anesthetics, and especially the intensive care unit. Because we have that guaranteed patient acuity in the intensive care unit, you're constantly dealing with patients who are life and death. A lot of patients in the intensive care unit will never leave the intensive care unit. And a large percentage of those that do leave the intensive care unit will have a significant change to their quality of life, their ability to live independently, their ability to work. So you have these exceptionally high stakes conversations. You need to be able to explain in very simple but detailed and clear terms the impact of a patient's illness or injury to their loved ones in a situation that might be the worst day of their loved one's life. A lot of the patients in the intensive care unit might have kissed their partner or wife goodbye in the morning and then gone and had a catastrophic accident the next day. And you're trying to not only console and provide empathy to somebody whose partner has almost just died, but also have these exceptionally high stakes conversations, both at the bedside and in more controlled and planned fashions that will guide the trajectory of that person's care and also allow for informed decision making and clear communication with the family to have an understanding of the significance of their stay in the intensive care unit.
Yeah, and some of those big decisions that we make, or intensivists have to make, is a decision of end of life. So it's a decision of what do you think would be the best interest, or what do you think the patient who is ill wanted, for the end of life care? When did they want us to stop? Where do they want us to provide them with CPR? And
Mm.
Queensland is one of those weird states where this is actually really hard decision making. The decision to actually stop treatment, and some people will go in there with, um, advanced health directives, which clearly state that, I didn't want any CPR, I didn't want to be on a ventilator, I didn't want my life to be prolonged, I didn't want artificial feeding to occur. And family members might not have that same view, and
Mm.
it creates this massive rift on what the patient himself or herself wanted and what the family wants for them. And then the intensivist is kind of caught in the middle, leaving them in kind of a legal limbo.
Mm.
um, can you just shed light for the general public on what that kind of is like, and what kind of decision making processes have to be going on behind the scene?
So I think there's a few things that I'd like to talk to on that point, if you don't mind, Arnie.
Yeah.
So I think the first is that there's a real lack of understanding from the general public about what intensive care measures can actually achieve. It's very easy to keep a lot of people alive, supported by strong medications and machines, all of which is exceptionally invasive. But that results in a significant derailment to a person's quality of life and independence thereafter. In the critical care realm, I've had innumerable discussions with patients with life limiting illnesses about decision making in terms of life prolonging cares. And there's so many people that value additional time so strongly that they, despite facing a terminal diagnosis, wish to have all resuscitative measures and a full spectrum of intensive care therapies applied to them. And it's my job in the intensive care unit to explain to these patients the significant impact on their quality of life. There's a lot of people that say, yep, do CPR on me, and don't realize the high percentage of people that suffer catastrophic hypoxic brain injuries and can no longer feed themselves, communicate or recognize with their loved ones. The percentage of people that come in with exceptionally severe surgical pathologies or life-threatening infections who become so horribly deconditioned that they can't go back to independent living, and they end up having to move into a nursing home and an assisted living sort of setting. And when you're having these sorts of discussions with a patient, it's exceptionally important to explore what quality of life that person would want to live.
What's
Now,
important to them?
what's important to them? Now, it's really challenging to negotiate these sorts of things in a high stress situation. And as such, I'm a huge supporter of this sort of decision making being something that is done in consultation with people's families, consultation with people's GPs in an elective fashion, having these conversations and these thoughts whilst you're not critically unwell, whilst your loved one's not on a ventilator, whilst your loved one's not immediately facing life or death decision making, so that when the worst does happen, and it happens to good people unexpectedly every day, those sorts of things are already in people's minds, and these conversations can occur in a fashion that more accurately reflects the wishes of somebody who they love.
Mm.
Now, I think the second thing that you spoke about was with regards to some of the end of life stuff and
Yeah.
the decision making and legalities around it. The second point that I'd like to talk to with regards to communication, especially in the intensive care setting, is there's an exceptionally small percentage of patients that die in the intensive care unit that are eligible for organ donation. And this is one of the most high impact conversations that you can have as an intensivist. You're dealing with a family whose loved one has died
Yeah.
and has no chance of ever coming off the machines that we have. And I'm talking here that their brain has died. It has lost all blood flow to it. It is an irreversible pathology, and in the eyes of the law, that person is deceased. And this exceptionally small percentage of people that this occurs to in the intensive care unit potentially have the opportunity to take this catastrophic situation and make it into a very generous gift that can help the lives of many, many people. Now, there's the Australian Organ Donation Register, but once again, these conversations need to occur with your family, because if you're that person who's died in the intensive care unit, your family are the ones that are the decision makers there. And whilst the Australian Organ Donation Register is a good way to reflect your wishes, your family will be the ones that a donation
Absolutely.
specialist and an intensivist will be having this conversation with, and they'll ultimately need to be making that decision. And there's a lot of people that, when asked if they would like to be an organ donor, would take that very positively. But
Yeah.
unless these conversations occur, your loved ones aren't empowered and informed to make these decisions on your behalf when you no longer can.